there is no mutation of the gene, and she was treated by Arius and Hexacil, and she stopped Hexacil since 2016. Concerning the other pathologies, nothing really important, diabetes and arterial hypertension. So this is the CT scan of you see the beginning of the presentation. As you see, she has huge renal polycystic disease and a normal liver. Okay, so the dialysis began in 2017, and during these years, she had 2 thrombosed humeral arteriovenous fistulas because she was under Hexacil. So the decision was to stop the medication, and the dialysis was then performed on a right jugular catheter. So she only received Aspergic. And the patient was then evaluated for the renal transplantation, and the checkup began in 2017, and you know that it's very long for nephrologists. So in June, 2 years later, she underwent a right nephrectomy to gain room to the renal graft, and this operation had an uneventful postoperative course. So the renal transplant was performed on October 2020. The graft had 2 arteries. The cold ischemia time was 22 hours. And well, finally, it was a bad trip because it was highly complicated. First, thrombosis of the inferior polar artery of the graft, and the graft never functioned. Lack of recovery, requiring resumption of dialysis at a rate of 3 sessions per week, and they didn't understand exactly this lack of recovery. And she had also an infected lymphocele treated by iterative drainages and then a lymphography. So this is the CT scan on November 2020 when the patient returned in dialysis. So as you see, the renal graft is not working very well. And I don't know if you noticed, the liver is not normal too. So in December 2020, she was hospitalized for anemia and discovery of ascites, and they suspected an hepatopathy decompensation. So she was anuric, and there was also a sepsis from the renal graft, a necrotic abscess with staphylococcus, and she was treated by antibiotherapy, began on January the 1st. And the decision was to remove, of course, the renal graft, which was not functioning, and explore the liver as disappeared. And these are the result of the different investigation during this year. This is the CT scan. To remove, of course, the renal graft, which was not functioning, and explore the liver as disappeared. And these are the result of the different investigation during this year. This is the CT scan. To remove, of course, the renal graft, which was not functioning, good for you, and explore the liver as disappeared. And these are the result of the different investigation during this year. View. This is the CT scan. To remove, of course, the renal graft, which was not functioning, good for you, and explore the liver as disappeared. And these are the result of the different investigation during this year. View. This is the CT scan.
Can you see the hepatic veins?
removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
Can you see the hepatic veins?
Removed, of course, the renal graft, which was not functioning, good for you, and explore the liver, disappeared, and these are the results of the different investigation during this year. View, this is the CT scan.
For that.
I'm sure it's impossible that the nephrectomy, the right nephrectomy done by lobotomy, had anything to do with that complication on the hepatic veins.
No. Lawrence, could I just ask, have your radiologist on the x-ray thought that this could be a NRH picture in the liver, nodular regenerative hyperplasia? I mean, she's been on a lot of drugs. I don't know whether any of them could contribute. And NRH it is a rare cause of Budd-Chiari as well. Was the
But
liver
it's not
biopsy?
really a bad query because, as you see, hepatic veins are completely normal.
Oh, they are, yeah.
There is something exactly like a diaphragm on the vena cava. So I really don't understand why it happened, because you saw that in 2016, liver and vena cava were completely normal.
I don't agree. I don't agree, Lawrence. I'm sorry. Because you see, that's possible to see the liver at the beginning, because when
Yes.
we saw the first CT, I was almost saying is something wrong at the time already. Second, this problem of this lady is a problem of coagulation. So there is something wrong with this blood coagulation, and it's not surprising the kidney don't work. And why you are so surprised with this blood Chiari?
Because look at that. Here, she has a complete normal liver. She has a vena cava which was perfectly normal.
Could you pass the CT slowly, please?
And can we see the venous? Because that's an arterial CT.
Yes, I know that, but as you know, that I only have this CT because she has a checkup for the renal transplant, not at all for the liver. So that's the only CT I found before all this story. But as you see, the liver was small, and I don't think there is anything with the liver before.
And I can't see collaterals. So
and there is no collateral. I agree with you, Maino. There is no collateral. She was perfectly okay with the liver.
Yeah.
And as you see,
so to summarize, he's developed an occlusion of the vena cava above the liver.
Look, this is the first one.
With patent hepatic veins. So one has to see now whether these hepatic veins are still patent.
They are.
The ascending operation.
Look at that. Look at that. They are. You have the hepatic veins here. Look at it.
I take your word for it. I'm not sure they are the hepatic veins there.
Look at that. This is the recent, very recent MRI.
Right. And in this case, you should do what I suggest is ascending operation, which I did with Gilles and the cardiac surgeon in a patient with a very similar problem. Anastomosing the up part of the liver, you open wide and join the hepatic veins and anastomose them to the right auricle.
Yes, it's exactly what I proposed, because I asked for a liver biopsy to see the degree of the liver damage, and there was not yet cirrhosis. It's only a vascular liver. So I said, we shouldn't do a liver transplant for this patient. Do not think it's not acceptable also. So the problem is, well, I'm wondering if I could put this patient on surgery, as a matter of fact, but try to combine an interventional procedure and on the surgical view, try to guide a stent, and if impossible, a shunt, as a matter of fact, between the retrohepatic vena cava and the right auricle. That's what.
Laurent, what are the symptoms of the patient today?
And that's the point. She is asymptomatic.
Yeah.
So look, at that time, you have the question of what to do for Budd-Chiari syndrome without symptom. That means she had not ascites.
Exact.
So
He had ascites.
No, today she has no ascites. Look on the MRI.
She had ascites.
At the time of the problem with the kidney. But after the nephrectomy, the ascites disappear. What you see. So look, I have a lot of patients, Budd-Chiari syndrome, symptomatic of course. that, were treated by potacaval shunt. And the trouble disappeared.
But the problem here is that the vena cava is the problem. So if
Yes,
I know. But
do you say, Professor Bismuth, that we should do nothing because she's asymptomatic? Because in that case,
it's very curious.
There is two concerns.
It's very curious. We don't see a huge collateral circulation in the liver. That means where the blood of the vena cava today is going to the heart. By which way?
She had, look at that, she had a lot of collateral in the subcutaneous tissue. And look at that, all on the subcutaneous tissue. It's visible when you examine the patient. She had enormous vein on the thorax, on the abdomen, on the back. And that is the only sign, because she has no ascites, no edema, nothing. But my concerns are two problems. First, it will evolve to cirrhosis or chronic Budd-Chiari, because look at the liver is not great on the CT scan here.
What is the function of the liver? You don't tell us about the biology of the liver. Today, what is the biology of the liver? Gamma GT, transaminases?
Yes, she has normal transaminase, only a slight cholestasis.
Transaminase, if transaminase is normal, the liver is not suffering. And it could be that the collateral circulation on the abdomen is enough. To compensate. Now, today, it could be that it is enough. You say, today, you are proposing a treatment for the future.
Exactly, because
the fear that there is cirrhosis.
This is the question. Look at that slide. For me, I wonder if it's useful to do something. So I said, why to treat her? And my concern are first the risk of the vascular cirrhosis, of course, and the second problem, even if it's true that transaminases are normal now. So I agree with you. The liver doesn't seem to suffer a lot, and this vena cava problem could maybe jeopardize the future renal retransplant, because after retransplant we could have decompensation of the liver, or it could be a venous hypertension on the renal graft, venous anastomosis. I don't know, but this is the concern of the nephrologist, to put her on a waiting list of renal graft.
But today, the hepatic vein are patent.
They are.
Yes, but the hepatic vein cannot join the vena cava above the obstruction. And you have the feeling that the obstruction is very small. But when we look at the vena cava is patent until the hepatic vein.
Exactly.
That means very, very high. And then, it is like you said, like a diaphragm. This is what you said.
Exactly.
This is very curious for a thrombosis.
This is very weird. I don't understand this patient, and I don't know, and that's why I'm asking all of you, should I do something?
Laurence, who's moderating?
To treat the image. Do you want to treat the patient for what? The patient is all right. If there is a problem like a diaphragm, it will be easy to understand that the diaphragm was already there when you show the first CT. And for me, the first CT was not already normal. See that CT carefully. There was something there is not normal.
Okay. Okay.
Laurence.
It's true. It is decompensated now because the liver has on the biopsy, well, it's not a normal liver, it's a vascular liver. So,
Yeah. Laurence,
yes.
who's moderating? Because I would like to speak.
Yes, I'm. Please, Pietro.
Right. I think this liver is suffering. And now it's the right moment to do something, because if I see what's happened in the liver from the first CT scan to now, there is clearly something very severe going on into this liver. I think that the normal flow has to be reestablished between the hepatic vein and the heart. How to reestablish it? It could be that a very clever vascular radiologist can break the web like they do for fenestrating aortic dissections. But what we did in a very similar case was a sending operation, exploring the web, and then either you take away the web or you resect that part of the inner cava and you anastomose through the diaphragm to the right atrium. I don't think that this patient can be left like that, and I would certainly not transplant this patient of a kidney with this degree of hypertension in the vena cava.
Eduardo.
Thank you, Pietro. That was my conclusion, in fact. But it seems that
I ask. Sorry,
Bismuth is not.
Henri, please.
No, I ask a question to Pietro. You said the liver is suffering. Why you say that?
Yes.
Transaminases are normal.
Yeah,
Why
but
for
because
the sign. What is the proof of the suffering of the liver?
The extreme change of that liver. How long between the first CT scan and the second CT scan, Laurence? I joined in late.
The first one was 4 years. 4 years.
Yeah. I mean, this is a completely different liver, and the biopsy shows hypertension, venous hypertension in this liver. Is it not true? So
Yes,
she will develop a vascular cirrhosis, what Laurence calls a vascular cirrhosis.
But, my proposal, I understand exactly. My proposal is more to observe the patient. And indeed, if there is real suffering liver, you will see the transaminase increasing. You may follow the patient. But to do a very important operation is this patient with renal insufficiency, waiting a liver transplant, a kidney transplant. I think this is risky. But my personal opinion will be to observe.
I agree with you, Professor Bismuth, because I think it's a very risky procedure in a patient with dialysis, and it will be, it's in a cardiac surgery. I completely agree that it is a risky procedure, but my concern is if I wait, she is symptomatic, wouldn't be too late to save the liver? Because if there is a cirrhosis, it will be too late. Will not be?
Nobody may answer to this question.
I don't agree. Please, look. Do you want to do a prophylactic operation for a problem in the future? In the patient is waiting for a kidney transplant and to ameliorate his life, the quality of his life. I think the priority on that lady is to have a kidney transplant working, and it's not because it's hypertension, vena cava hypertension that this graph failed. Obviously, it's not. I have the experience of more than 3,000 kidneys. I have a lot of this problem. It never happened a problem of cava hypertension as a cause of failure of the kidney. So I think.
Eduardo.
Yes,
Eduardo.
Pietro.
How many kidneys you transplanted with caval thrombosis?
But what caval thrombosis?
This patient has a caval obstruction.
No, I don't. No, we don't transplant patients with kidney.
But that's why, in your experience of 3,000 kidneys, you had good nephrologists who never gave you a patient with caval obstruction.
Yes, of course. But you think that patient has a caval thrombosis?
Yeah.
No, I don't think so.
Yes.
I think it's more
a web or whatever. I mean, mechanically, she's got a caval thrombosis.
Well, she has a vena cava hypertension. So I'm afraid of a venous thrombosis in the renal graft because of this.
Or simply in the Budd-Chiari of the she would have a Budd-Chiari of the kidney.
Laurent, you said she has a caval hypertension. Yes. Do you have the figure? It is easy to have the figure. For if there is a good compensation by the collateral circulation, the pressure in the vena cava is not normal, of course, but is slightly elevated. May you have the figure of this? When they did the catheter, surely they have the pressure.
I don't think they measured the pressure in the vena cava. It would maybe interesting. They didn't do that. In fact, they did that to put a stent, in fact. So they saw that it was obstructed, so they didn't measure. Maybe we could do that again to answer this question. But I presume that the pressure will be high. So what is the good pressure to do an anastomosis with the iliac vein? I don't know. It will be also a very difficult renal transplantation, probably. So it is a supplementary risk for the renal kidney transplantation. So I understand. Most of you said that I shouldn't do anything for this asymptomatic patient. No prophylactic surgery, except Pietro, who is thinking exactly like me. I am anxious to do something, but I don't know if I'm right. So maybe other companions can say what they think.
May I ask who the companions are watching? Who agree to do this prophylactic operation in a patient, a symptomatic patient at this time now?
Can I say I sort of agree with Pietro. I think this patient will only get worse. Looking at the CT scan, it's a dramatic deterioration, and this patient is not well, needs a renal transplant. I think if we wait for the patient to become symptomatic, she will be too unwell for treatment and certainly too unwell for transplantation. I think there's a window now, and now I agree it's a difficult procedure, but I think the window period to treat is now.
Thank you, John. I like when you agree with me.
Laurence, at the end, the staff is only giving you advice, and at the end, you decide. So you listen.
The problem, Professor,
you listen what we said. I think that if the pressure of the vena cava is not high, there is no reason really to do any kind of surgery. There is patients with hypertension with a very nice collateral circulation, and there are no symptoms of the collateral circulation. Sherlock in the book said that in some patients, the collateral circulation succeed to decrease the pressure of the portal vein. She said that. I never studied that, but in his famous book, she said that. She observes a patient with important collateral circulation, and the pressure in the portal vein is almost normal.
Thank you, Professor. I was with a difficult decision to make, and now it's more difficult because your advice is completely the contrary of Pietro advice. Thank you very much, guys.
Okay.
No, Laurence, I mitigate my advice. I think a clever vascular radiologist may break the web.
I have really a good radiologist. He tried twice.
Look,
then
so
operate on him.
And he
the Sherman
functioned the pericardium.
May I, as a chairman, say something? It's a very nice case that now the decision is Florence to take the decision alone in Bordeaux, and we can move to another case. Fernando.
Yes, Professor Barroso, thank you very much. I was just wondering to give an opinion, if I may.
Right, the last opinion, okay, thank you.
Yes, I was thinking, because I wrote it, but better to explain it. I think this patient had a huge kidney that may chronically have positioned the liver in certain way that after the nephrectomy, it may have kinked the hepatocaval junction, just as may right hepatectomy, and that's why we fix it. So if we think, because I didn't see really a thrombus in the studies that you showed, Professor Chiche, why not to reposition the liver by laparoscopy with an intraoperative hemodynamic study to see if that works? And if that works, probably just the PEXI during laparoscopy might be a possible solution with a very low risk.
Thank you, Fernando, because you had exactly the same opinion, the nephrologist, and I said that it was impossible to do that because the liver is entire. And if you see the CT scan, the liver is occupying the space very well, and usually I don't think it's the ptosis of the liver. Honestly, I just made reconstruction and all, but it was, of course, a hypothesis. But I don't think it is possible now. The liver is very big and empties all the space. It is impossible to do anything.
Okay, just an opinion. Thank you. Thank you very much.
Thank you very much.
Let's move to another case. Professor Bismuth, do you agree?
No, Hugo.
Yes.
But the next chairman, who is the next chairman?
So we have Pietro as chairman also.
Yeah. For which case, Hugo?
Well, we have a case from ourselves, Oscar also, and your case.
Yes. So why don't I moderate your case, Hugo?
Very well.
And then you do the reverse.
Very well. So I'll ask Beatriz to start. She's one of our residents. Beatriz, are you there?
Yes. Hello.
Okay.
Good morning.
You choose present now.
Sorry. Okay, so can you see?
Yes.
Yes. Okay. Thank you. So first of all, I would like
just to add, this is a case that is not completely solved.
Okay.
I would say half solved, if you agree. Please, Beatriz, go ahead.
Yes. So first of all, I would like to say good morning to everyone and thank Professor Hugo for the invitation to present here. So I will begin our case. So it's a 74-year-old female with a personal history of hypertension and iron deficiency anemia. So during the course of this the study for this anemia, she did an endoscopy which found a peptic ulcer scar in the incisor angularis, and also a colonoscopy which was pretty unremarkable. So she did a CT scan as well, an abdominal pelvic CT scan that showed this hepatic mass, which is a central mass encompassing segments 4, 5, and 8, roughly with 11 by 9 centimeters. I'll show it again. So this was her MRI, just to show the size of the mass and the relationship with the bile ducts. Here you can see that the mass appears to be cyst-like, with some solid areas around the border as well. This is different from the ration. With some left, mainly left duct dilation already because of the left duct compression. So her CEA, CA19-9 and alpha-fetoprotein levels were normal. A serology for hepatic cyst was also performed, which was negative, and there was no extra hepatic disease. This is now her arterial scan. Here you can see that the right hepatic artery comes directly from the aorta. Here, sorry. Here, and it appears to cross straight into the lesion, while the left hepatic artery comes from the celiac axis and looks okay. This is her portal scan. So the middle hepatic vein is severely compressed, as well as the left portal vein, which is they called it critical stenosis here. I'll show it again. This was all done before reference to our center, and a biopsy was also performed that showed it was compatible with an intrapapillary mucinous neoplasm of the bile ducts. However, we thought that maybe the radiological aspect was more suggestive of a cystadenocarcinoma. So what would you do now?
So at this point, it was referred to our center.
Yes.
Right. Who would like to say anything?
Can you put again the MRI, please, Beatriz?
Yes, of course.
I mean, we agree with the diagnosis.
So which?
Do you have
Laurence has raised her hand.
A T2
Yes.
sequence, please.
Pietro.
I agree with the diagnosis, Pietro, as a matter of fact, but I'm afraid it's very unresectable because the problem is not the hepatic vein or the artery. The problem is the portal confluence. Because
Yes, can we? I mean, now I just want to make sure there is consensus on the diagnosis and that we can accept it, Beatrice.
Okay.
All right.
All right.
Can I?
Now the question is it resectable or is it not resectable?
Pietro, may I just interrupt you on the diagnosis?
Yes.
Because I think that mucinous intraductal papillary neoplasm of the bile ducts is usually an intraductal lesion and not really a cystic tumor. So
But, we said cystadenocarcinoma in this case.
yes.
That was the diagnosis on which I ended up.
Yes.
Yeah. And so this is a cystadenocarcinoma.
If
Is
I
it
may.
resectable?
if I may, Hugo,
Yes.
of course, it's intrapapillary, so it is within the bile duct, but sometimes, and I saw that it begin like that and then expand in the liver, and it can present as a huge mass like that. So we see in that CT that the bile duct was obstructed. So maybe it began with intrapapillar and began a cystic tumor. It is possible to have huge tumor, and it is the diagnosis of intrapapillary.
You know why I may dispute that. You can see dilation of the bile ducts on the left, but not on the right, and the patient is not jaundiced.
Of course, yes, but I think that it can be something. It can be a compression of the biliary duct, but it can be also thrombus in the bile duct.
Yeah. Now, can we now see whether this tumor is resectable or not, and how? Which I think is the question that is being asked to us.
Yes.
And
can you show the MRI, Beatrice, the relation to the vessels?
And we should see better the CT scan. For me, in particular, the left portal vein.
Okay. I will just show this one.
Here.
And then...
No. Is compressed.
Okay, so
And
portal vein here.
on the right now.
The left and the right are concerned.
Yes, compressed, invaded, difficult to say.
It is surprising, but it's not thrombosed. It's just compressed.
Yes. And this patient is not jaundiced.
Not yet.
Yeah. So I would assume that she's got some sort of compression, but not invasion of the portal pedicles.
You are less aggressive now. Second case, less aggressive. In first case, it slowed down the aggression, the surgical.
No, I think I would like to explore this patient and try to resect this. I mean, maybe the veins and the portal pedicles are just compressed and not invaded by the tumor.
Okay, can we move forward?
Yeah.
Okay, so we discussed this in our meeting and decided to do a right portal embolization with a right hysterectomy extended to segment 1, probably with a vascular R1 being necessary. So this is her portogram, which showed that there was almost no flow through the left portal vein. So we couldn't do the right portal embolization. And I would like to ask again, what would you do now?
Maybe I have a crazy idea. To put a stent,
Go ahead, Laurent.
To put a stent in the left portal vein to reinstore the portal circulation in the left, and then embolize the right.
Laurence, but why do you think in the end that keeping the left is better than keeping the right? Just on a quick look at this case, I don't think that the left is any better than the right. So I would need some more time to choose between right and left, or maybe just try to accept an R1 and take the tumor away. And maybe
the right hepatic vein is not compassionate.
Yeah. It's compressed. It's compressed, the right hepatic vein.
More than compressed. But
let's say compressed. I don't know whether it's more than compressed.
It's a tumor of segment 4, 8. Well, it's a central tumor, of course, But anyway,
for me, the right hepatic vein was not too bad. It was retrievable, let's say. You see? Well, it's certainly no worse than the left portal vein, which is all surrounded by the tumor.
The tumor is in segment 5 too.
The tumor is almost everywhere.
Yeah. Yeah.
But I would try to accept an R1 resection for this tumor.
We decided
would be a left trisectionectomy. You would skip segment 6 and 7. Could be an option.
Yeah, could be an option.
That would be my option now, looking at it.
I propose a plan B. A plan B, perhaps, if this is the plan A is as Hugo said, but I think that if in the exploration you can confirm that the left portal vein is only compressed, you can perform a central hepatectomy. It means segment 4, 5, and 8, keeping the left lateral section. I think the segment 2 and 3 are very, very well. The left hepatic vein is patent, and you can perhaps perform such operation if the left portal vein is only compressed. That at least we cannot see now if it is invaded or compressed.
Mm-hmm.
What do you think about that?
But I think if the veins are invaded, it's too late. If the veins are compressed, probably a central hepatectomy would be possible.
That's why I say
because okay. What I'm saying is that
what I said. Thank you.
Yeah.
Okay, Beatrice.
Okay, so after this, we discussed it again and decided to do a left biliary drainage by ERCP because the patient was jaundiced and keep with the original plan.
Sorry, but at this point, the bilirubin started increasing by 2.5 around that, and as you saw, we had already dilation of the left bile duct.
Yes, and keep with the original plan to do the right tricectomy, but with the portal reconstruction of the left portal vein via ALPS. So we did the ERCP and placed the biliary stent, and there was some drainage of mucus from the main bile duct, which you can see here. And then we did the stage 1 of the ALPS procedure on the 12th of January. Here you can see that there was a resection of the portal vein with reconstruction to the main duct. So the left portal vein was reconstructed.
I may add that what we saw intraoperatively was that in fact most part of the portal vein was compressed, although in the confluence there was actually an invasion, and this was the reason why we opted for a portal reconstruction instead of only detachment of the portal vein.
Mm-hmm.
And here you can see the split with the tumor now exclusively on the right side, on the right tricectomy future piece, and the left side is free of lesion. So her post-operative period was unremarkable. There were no complications, and she did this CT scan, a volume CT scan 1 week post-op. We showed that the segments 2 and 3 had an FLR of 32%. Now we scheduled the second stage for the 2nd of February, and with another volume CT scan next Monday.
Splendid.
Mm-hmm. Yeah, I'd be very interested to know whether we can resect the whole tumor, in fact.
I ask a question. Why you did not do the double embolization also of the right hepatic vein and
The embolization. So
yes. The hepatic vein. This is a question. One your question. Why you decide to do the section instead of doing the embolization of the hepatic vein?
Because first we tried the embolization before the operation, and we didn't have a patent left portal vein. So we had.
Speak about the hepatic vein. The hepatic vein.
But I think, Henri, what he said is that having no flow in the left portal vein, he had no chance to embolize the right. He had first to do the reconstruction of the portal vein and then choose whatever. I mean, he chose ALPS, but he could have closed the patient and do multiple embolization at that time. But I think ALPS is Laurence.
Yes, Hugo. I thought that it was the first step was to reinstore the portal vein.
Yes.
So you did very well, because I would have done a portal stent, but I would have been wrong because it was invaded. So you did very well because you resect the portal, the left portal vein, and after the ALPS is a very, very good idea. In that procedure, because the left lobe was right, and the left hepatic vein was also very well and quite far from the tumor. So I think that you did very well.
Yeah. Well, in fact, I think it's the best indication I ever saw for ALPS.
I agree.
The only indication I saw for.
I agree.
Yes. Now I understand. For the indication was also not only the ALP, but also the restoration of the
ALPS was a secondary procedure that he did, but the main procedure that he did was reconstruction of the flow on the left portal vein.
Not only reconstruction, but removal of the invaded left.
Yeah.
Yes, that's
Absolutely.
clever.
Hugo, very well done. We are looking forward to the final result.
Next week.
Now, Hugo, will you moderate the next?
Okay, of course.
So, but we said congratulations for the Hugo and his team about this case. Okay.
Thank you very much for everyone. So
yes, there is somebody of my staff, Hugo, that is asking for a follow-up of this case and the final pathology.
Of course. We'll keep you updated.
Yeah, it's, Alessandra, my candidate to become compagnon one day. And this is one liver case from Lugano, and we really want your advice on this case, which is, I think, very exceptional. Lorenzo, go ahead.
Who is the chairman for this case?
Yeah, it's me.
So good afternoon, everybody. Thanks to Professor Minor and all the companions for letting me present this case. I want to ask you if you see my screen.
Now we do, Lorenzo.
All right. This is the first of 2 liver cases. Okay. So it's about a 33-year-old lady, 4-week pregnant, BMI 28, with 15-year-long use of oral contraceptive, which was stopped in September 2020. She's medical history, so some autoimmune diseases, asthma, and she has familiarity for diabetes and breast cancer. So she was found with slightly increased gamma GT, for which she had an ultrasound. The ultrasound, I do not have the image, but it showed hepatomegaly and the 7 per 6 centimeter nodule of the right hemiliver involving segment 6, 7, and 8, dislocating the right hepatic vein, isocogenic, encapsulated, for which a diagnosis of FNH was suggested, or even angioma or adenoma. So I would like to ask you, what is the further investigation, given the fact that the patient is asymptomatic?
Yeah, Lorenzo, sorry, this is not the case I was thinking, but this is a very interesting case, but not that rare, for which I ask your opinion later. I think you can go ahead, Lorenzo, to give the diagnosis. And this showed the CT scan. and the MRI.
So the second case,
No, just on this one.
yeah,
On the first one, it's a big focal nodular hyperplasia in a 33-year-old lady, 4-week pregnant, with gamma GT elevated.
yeah.
And what we wanted to know is that can we really say to this patient, for which our radiologist is happy that it is a focal and nodular hyperplasia, since we have a diagnosis of certainty, we don't need follow-up. Who would follow up this patient?
You say she had gamma GT increase. That
Yes,
means
she's got,
that means cholestasis.
yeah. But I think this is what I said, that you have the right to have gamma GTs in focal nodular hyperplasia. Our radiologist is adamant. This is no doubt focal nodular hyperplasia. 33-year-old, should we say, forget about it and come back if you are symptomatic?
Yeah.
Laurence has zillions of these patients, so I wanted her advice.
Do you regularly follow these patients, Laurence?
Laurence?
You are muted, Laurence.
Gamma GT are often increased in focal, in huge, and particularly huge. It is not cholestasis because alkaline phosphatases are usually normal. It's only gamma GT. Anyway, this patient has a classical, undoubtful hyperfocal nodular hyperplasia, and I think that it doesn't need any follow-up. So I just said, good luck for your kid.
But why not do not do a follow-up once a year? Just to
but this is what
why
let's
not
debate that.
to see the patient once a year, to see with the ecographic approach if there is a size difference of size, to speak a little bit with her. What's the problem to follow up?
The problem, I can answer the problem.
Yes.
Because in 1 year, she said, oh, it increased of 1 centimeter. What are we doing? Nothing. So the next year, maybe it's a little more. So what would you do? It's a anxiety. It is.
No, it's fantastic to have. She felt some human approach only. That's not a technocratic approach. Of course, that patient needs to be seen once a year just to speak a little bit and tranquilize her. What's the problem? If you don't abandon her, okay, send her to another patient, another doctor.
Eduardo, you
Yes.
will not be able to tranquilize her if the focal nodular hyperplasia increases.
No,
I
that's
think-
not true.
But it's not right. Okay.
Right. Can I ask Professor Bismuth's advice?
No, I think, on one way, it is not difficult to remove by enucleation. Really, look, it is, of course, you need to do total vascular exclusion, but I did that for focal nodular hyperplasia, a huge tumor, and she's young, she's very young, and but this is too extreme for me. I think I will stop. But I agree with Eduardo. I will follow a little the patient, perhaps not every year, but in 2 years or 5 years to see if it increases. She's 30 years old with already a large HNF. I will follow. Surely I will follow in 1 or 2 years to see if it increases. So I agree with Eduardo.
You know what happened? If you abandon this lady, she goes to another surgeon, another surgeon operated her. If she felt abandoned, he goes to another center, another surgeon says, oh, look, this is dangerous, this may be malignant, and she was operated otherwise.
So Oscar wanted also to have a comment. Please, Oscar.
Yes. Well, I think that elevated gamma GT can be also attributed to pregnancy, not only for the focal lesion. But I agree with Eduardo that I should prefer to make a follow-up, not so frequently, but once a year. Even these huge masses can become symptomatic in some time. Even if it's a focal nodular hyperplasia. So once a year, it is not very problematic for the patient. And I think that it also reassures not only the patient, but the surgeon as well. So I prefer follow-up once a year, at least for 3 or 4 years. I don't know, but perhaps you can make the follow-up longer if you see that nothing changes. But otherwise, I prefer to follow up this patient.
Agree.
Can I ask the advice of Surendra and of who else?
That lady goes to Heidelberg.
Gina
If that
raised
lady
her
goes
hand.
to Heidelberg to see another opinion, she comes from Heidelberg with a hypertechnically then.
Eduardo, because I'm very respectful of the age and wisdom of all the people I are here. What I would do for the patient, that the only way I can reassure the patient that I found is no follow-up and come back to see me if you have symptoms. This is, for me, the strongest reassurance so far. I give them my mobile phone. If there are symptoms, ring me. But otherwise, no need for follow-up, because otherwise we go into that loop that Laurence described so well. It increases 1 centimeter, then another centimeter, and then I retire, and she becomes, she's left with anxiety with Alessandra. So I think I would not follow up. But Surendra and
So, Petro, that I can't say, as far as the age is concerned, myself and Eduardo share the birth year. Eduardo will remember. Okay, we are both 1949 born.
Yes.
So I can't claim my any seniority over Eduardo. What he's saying. Okay. So from that, I look at this way. What is the risk of bleed from this? Spontaneous rupture, and if that is not there, what you are saying, if it is asymptomatic, observe. But there may be other view which say the patient psychologically under pressure if something goes wrong. So you may advise that, okay, sit home tight. If you become symptomatic, come back. But the patient may go for second opinion, third opinion, and may go into the circles. So both ways can be the right way.
good.
Very good.
Now, Lorenzo has a difficult case. This one is an exceptional and difficult case.
Yeah. So the conclusion. Pietro,
I will not tell anybody.
So Pietro, you decide to not follow the patient. This is the
secret of my outpatient. I will not tell anybody.
Okay.
Okay. So let's move to.
You still see my screen?
Case. Yes, Lorenzo.
All right. This is about a 66-year-old male with history of adenocarcinoma of the rectum in July 2016, which was treated by neoadjuvant radiochemotherapy and then anterior rectal resection. At pathology, we had PT3, N0, G2, N0, R0 also. So he also has a liver cirrhosis, child A, based on NASH and alcohol abuse, and also history of diabetes type 2, hypertension, obesity, and history of hepatitis B. So at follow-up CT scan in October 2021, he was found with 2 new lesions, suspected of being colorectal liver metastasis in segment 5-6. Here you see the lesions. So we went for a full workup with gastroscopy and colonoscopy, which were normal. All the tumoral markers were normal. And we did a liver-specific MRI, of course, in October 2021, which showed 2 nodules in segment 5, 1 nodule in segment 6, and 2 very small nodules in segment 8. So a total of 5 lesions, which were radiologically suspected of being colorectal liver metastasis. So what would you do after you see the image? The small lesions, almost invisible. The other are there.
Yeah.
Another one. Hepatobiliary phase.
Yeah, one is there, you see. And then 3 others are down below, easily accessible.
So it's 5 in total.
5 in total, yes. So this is the total. So you see the small in segment 8, the 2 small, a little big one in segment 6, and 2 in segment 5. These latter 3 are easily accessible.
And
okay.
And we biopsied them because the radiologist said, well, they don't have the look of liver metastasis. And we biopsied them, and it became that they were cholangiocarcinomas. And we said, we don't believe that. I mean, I've never seen 5 cholangiocarcinomas developing in a patient with a rectal tumor. And we did NGS.
So, Pietro, first of all, why did you decide to biopsy those lesions in this context?
In fact, it was not us biopsying it. It was before the patient came to our attention, and I think because the radiologist smelt that these were not typical of liver metastasis on the MRI. And right he was. And we did next generation sequencing to this because we did not believe that these were cholangiocarcinomas. And NGS said, no, on the biopsy, good sample, this is cholangiocarcinoma.
This is, other than that, this is a very atypical presentation for cholangiocarcinoma also. I think Laurence wanted to say something.
I think they were right to do biopsy because the patient had a liver cirrhosis. And I saw that in the CT scan, it was hypervascularized. So I would have done a biopsy too. The problem is that it is possible on liver cirrhosis to have cholangiocarcinoma. The problem is, are all the nodules the same? Because maybe you can have, in cirrhosis, hepatocellular carcinoma and cholangiocarcinoma, which frequency is higher in cirrhosis. So this is difficult. So are all the nodules the same pattern?
Yeah, yes, they were, I think. Yes, they were.
They were?
And
radiologically, they were the same pattern. Yeah. But we said clinically, I mean, this is, as we were perplexed, as Laurence is it all the same thing? So we decided.
So, Pietro, just one thing about the fact that they are all the same thing. Is the pancreas also totally free of disease? This could be the metastasis from a cancer of pancreaticobiliary.
We did everything.
Yeah.
Okay.
And these were the only lesions. So we resected laparoscopically the 3 accessible lesions down below.
Yeah, so we went for liver resection, laparoscopic, non-anatomical liver resection, 2 in segment 5 and 1 in segment 6. And we planned a laparoscopic assisted ablation of the smaller lesion in segment 8. We did not perform a hilar lymphadenectomy. However, in the intraoperative theater, we did wedge resection in segment 5 and 6, but we were unable to find the segment 8 lesions at intraoperative ultrasound due to the multinodular cirrhosis. Yeah.
Lawrence, is that the left-sided gallbladder?
Yeah, it is.
Okay.
And then we confirmed that all 3 lesions
were 3 cholangiocarcinoma, small duct type, PT2 multifocal, G2, R0 of the 3 resection we did. Yeah. No vascular.
And now we are left with 2 small claquettes de mouche in segment 7 in this patient who has cirrhosis, BMI of 33, 65-year-old.
Yeah, this is the...
What should we do?
This is bad.
Beyond that.
This is a very strange case, for it is multinodular cholangiocarcinoma, small size, without primary cholangitis, of course. And it is very, very strange, and I think very. This is. I am very upset about this case. For
there is one good.
It could be many. It could be many tumors, all inside the liver.
There is one good thing. While this patient was worked up we saw that there is no evolution at all in the size of the tumors between October and December.
Yeah. So this is a thoracoabdominopelvian CT scan.
Low evolution disease with 2 very small residual of 4 millimeters and 7 millimeters in segment 7.
So, I mean, what do you think is to wait and ready to do another operation in case you have other tumor? This is what you think?
No, what I think is that this patient should be transplanted.
May I ask Pietro, Ugo, what kind of rectal tumor that patient is the
83 and 0.
No. I don't know the staging. Histologically, what?
It was an adenocarcinoma. Yeah, adenocarcinoma. Yes.
And have you seen this picture?
No, we did molecular analysis, and there are 2 different things.
Yeah.
You do everything. So my question is not, you have done already the molecular analysis, so you have the same thought as me. That could be the same tumor.
I have a question. I have a question to Pietro. Pietro, do you transplant a patient with a rectal cancer, RAS mutated and TP53 mutated, with a short history? It's not a long history of rectal cancer. So, do you put in the list a patient like this for liver transplant? Anyway,
he will wait 2 years for his transplant anyway. And what I would do in the meanwhile, I would do bariatric surgery on him to cure him from his diabetes and to make the transplant easier. And allow myself a window of time to confirm that this disease is exceptional and very low grade, and transplant him in 2 years' time. This is what I would do for this patient, because his story is exceptional. I will demonstrate his story is exceptional by waiting. And while I wait, do the bariatric surgery.
Laurence wanted to have a comment.
Well, for once, I would not consider liver transplantation for this patient because first, as you said, it's exceptional to have this multifocal cholangiocarcinoma, but it's not a good prognosis, even if you think that in 2 months it's not evolutive, but it is all right, 4. 4. But it's a multifocal disease first. Second, we know that liver transplantation has not very good result for cholangiocarcinoma. Third, the problem is the rectal cancer, because you need to wait at least 5 years, not 2 years, to transplant a patient with this type of cancer. So the point is, this patient need a treatment for his liver, but not for me, liver transplantation. The problem is the treatment for cholangiocarcinoma is not working very well. So I am concerned, and I'm quite upset with that patient.
But what do you propose, Laurence?
Well, I think that this patient should be, well, I would ask oncologists for the best treatment for this patient, because there is residual. The operation was very interesting to have a diagnosis, but this patient is not cured. No. So we have to treat him. Surveillance, well, we know what will happen. Liver transplantation, no. And, well, adjuvant treatment, yes, but what treatment? I don't know. It is gemcitabine and cisplatin, maybe? Well, I don't know.
Yes, I think, yes.
Okay, Valerio, I think you had also a comment to make.
Yes. Pietro and Lorenzo, I was wondering, you went for cholangiocarcinoma you knew it preoperatively, and you are advising a quite aggressive attitude for this patient. Why didn't you consider a lymphadenectomy, which is guidelines for cholangiocarcinoma, intrahepatic cholangiocarcinoma, during the laparoscopy? Because this might be, if there is a lymph node metastasis, this would change all the story of this patient.
If I may answer, maybe we didn't believe the biopsy.
At that time, I was still convinced it could be metastasis.
Yeah, I agree with you.
And I said, this is not. I mean, we will show them that this is metastasis, because I've never seen cholangiocarcinoma presenting like 5 small, yes, very stable nodules. And I think that if this patient has aggressive cholangiocarcinoma that cannot be transplanted, we will soon learn it, and then he will go into chemotherapy. But what I hope for him is that his disease will still prove to be exceptional, and in 2 years' time, we will have the window of observation from the rectum and the possibility to transplant him, because his tumors will be small. In this moment, I can't do a resection. We could do a right hepatectomy or a segment 7 resection, but we cannot find these very 2 small residual nodules. So the only thing I think I would do now is observation for this patient.
So you propose the test of time for this patient?
But Pietro, no chemotherapy, no adjuvancy?
Valerio, about the lymphadenectomy, this patient has a cirrhosis.
Yes.
And there is a high risk with lymphadenectomy to have an ascites.
Well, he is totally child A patient. On the image we saw from the laparoscopy, it seemed not too difficult to do a lymphadenectomy. At least a couple of, usually we should take out 6 lymph nodes for the guidelines. But I think if you take the lymph node of the faux de l'artère hépatique and the right side of the pedicle, would be also already okay for to exclude metastasis at this level.
But
Laurence?
no,
I think you are muted. Cannot hear you.
Sorry. If you do lymphadenectomy now, it's because you want to validate the option of transplantation, right? So I think, and I bet, that in 1 year, if you do nothing, this patient will give you the answer. He will have a multifocal cholangiocarcinoma.
yeah. And so I would not push for lymphadenectomy now. It's not the typical cholangiocarcinoma that you resect and you do the lymphadenectomy.
Exact.
No, I agree. I wouldn't do it now, but I would have done it during the laparoscopy.
No.
I take it, but I think my assumption for this patient is still that he has the exceptional, very small, and quiescent cholangiocarcinoma.
You are a terrible optimistic guy.
Yeah, and we will know it. We will know it in 1 year or 2 years' time.
Let us know.
Okay.
Yeah.
Okay.
Lorenzo, thank you very much. You wanted to show the slide?
So, which slide again?
No, that's fine. Okay.
Okay.
Thank you very much.
Very nice case. Very nice
Thank you,
case.
Pietro. So we move to the next case and the next moderator. Next moderator is John Isaac, and it is Oscar's case.
Thank you, Hugo. Thanks, everyone. So, Oscar, you have a case for us?
Yes.
Please carry on.
Lorenzo, can you interrupt the share screen, please?
Lorenzo.
Yeah. Yep. I think
Is it
he's doing
okay?
that now. Yeah. He's stopping to share. Okay, Oscar.
Okay.
Yeah.
It's okay.
You can share now, Oscar.
Well, sorry, I have to present this in this way because it doesn't work otherwise. This is a case that I have to share with you. The opinion is a female, 42 years old, history of hormonal intake for fertilization in 2020. She was studied for chronic anemia, and she had no other complaints, no pain, no fever, no weight loss. In the physical examination, a palpable abdominal mass led to perform an ultrasonography showing solid masses in the liver. I cannot show the ultrasonography, unfortunately. In the interrogation in 2015, she consulted to a medical ward for abdominal pain. She had an ultrasonography and was informed as liver hemangiomas. The blood test she had at that time, at the time of the examination, a hematocrit of 39%, white cell count of 8,000, platelets 535,000, normal bilirubin, normal transaminases, normal phosphatase alkaline, and only a saturation of transferrin that was a little bit low, with normal tumor markers. I will show you the MRI that was performed. Can you see it? You can see huge tumors with heterogeneous contrast intake, and a lot of tumors in the caudate lobe, in the right hemiliver, and even in the left hemiliver. This is also an arterial phase in a coronal view. You can see a huge right liver distorting also all the vessels, even the inferior vena cava, the retrohepatic inferior vena cava. This is the CT scan. You can see also little hypervascular nodules scattered in the liver. This is a coronal view. This is a portal phase. So what do you think about in the diagnosis, multiple adenomas, multiple atypical hemangiomas, or other diagnoses? What do you think about?
Right. So, Oscar, in 2015, she had an ultrasound, but we don't really know. They said hemangiomas, but again, that could have been adenomas even at that time. We won't really know, will we? And now she's had recently hormonal therapy. Is that correct?
Yes.
Hormonal therapy for IVF or something. Okay.
Absolutely.
And I imagine we're looking at the diagnosis, but just to clarify, she must be very symptomatic, I think. Big mass, abdominal distension. Is that correct?
She hadn't any symptoms, only a palpable mass in the upper abdominal part of her, but nothing more. She's really asymptomatic.
Okay. Right.
She runs a normal life.
Right. I think probably overall, common things being common, this would be adenomas, but I'd open it up to the floor for any opinion. Yeah, Pietro, got you?
I had to answer a telephone, so I missed the CT scan, unfortunately.
Oh, you've missed something quite special.
Do you want
to run it through again?
Okay.
Oscar, please. Yeah.
Yes.
No.
This is the arterial phase.
Yeah.
You can see a huge right hemiliver, reaching almost the pelvis.
And the biopsy is adenomas?
No. We didn't biopsy at that time. I'm just wondering the diagnosis.
I would not.
What would you, Pietro? You want to say you would do a biopsy? Is that correct?
Yeah.
Yeah. Okay. I think that is quite reasonable. We are a very large mass in the liver, and we are concerned what this is. I think a biopsy will probably guide the management. Does anybody think these might be hemangiomas?
It was informed as hemangiomas in 2015, and some radiologists said that it could be some sort of atypical hemangiomas, but we didn't think about this. We thought that it was multiple adenomas, and as Pietro said, this is all the things we thought: percutaneous biopsy, laparoscopy, or other behavior. But we performed a coaxial protected biopsy. It was endothelial cells proliferation within liver parenchyma, in parts as vascular conduits and in parts as solid masses, with CD31 and CD34 positive, and the conclusion is an epithelioid hemangioendothelioma.
Okay.
So my question is, what do you propose to this lady? Liver transplantation, a stage resection, or other option?
So these tumors are, I think, quite well known, and we know the behavior is relatively unpredictable. It can progress very rapidly to a malignant state quite rapidly. So decision making, I'm not sure if resection is going to be an option. Can we look at resection first and see if anybody thinks they can have a surgical plan for this patient given the distribution of the lesion? Does anyone think resection is possible? I think it'd be a brave person to. Lawrence, I believe I saw you shaking your head. I think you would not consider that a resection is feasible here.
No, definitely transplantation if it's not too late.
Okay. So the approach would be transplantation. Oscar, what does your team think about this?
We thought also about liver transplantations, but before propose the patient, I rather wanted to share with you this option. CT scan of thorax is normal. There is no other extension so far. And another question that I wanted to do is which kind of workup do you perform before put these patients in the waiting list?
I would, just a second, I would take, if I may, who moderates?
I do, Pietro, please go ahead, yeah.
I would take issue with Laurence if it's not too late, because these are tumors that you can transplant even if they have metastasis.
Because there's a certain cohort that have a very slow-growing behavior. Is that your feeling, Pietro?
Yeah, and at least within the fact that they are unpredictable.
That's right.
Yeah.
The patient
That's
is
why I agree with John. It is unpredictable. I had a bad experience on that once. So, but you're right. It's possible to transplant patient with some metastasis. So you have to transplant after a checkup. Well, what you did usually for that. So thorax, bones, etc.
So it would be interesting, looking at different programs, whether you could list a patient with hemangioepithelioid hemangioadenoma with metastasis. I would say that it's a rare indication for transplant, and in the UK, for example, we put it through and there'd be an appeal and it would probably be approved for transplant, but if there were metastasis, it would be turned down for transplant. That would be the conservative approach here. I can assure you of that. I'm not sure whether, in other jurisdictions, whether they would consider transplantation even for metastatic disease.
And do you perform this? Do you think that do you prefer to put in a liver transplant this for living donor transplantation or for cadaveric donor? Do you have some issues about liver allocation in these cases? At the time I performed liver transplantations, we performed twice, and they were with living donors. But I don't know, how do you manage this issue?
Jan Lerut is the world expert on that. And he published the LTR series. And I don't know how many metastases there were, but I think in Geneva we transplanted one patient with metastasis and has done well since. And in Paris, I remember when I was there, you transplanted one patient and then went back taking out 16 lung metastases in this patient. And I don't know how he did, but that accessed by on Jan Lerut's paper. And he certainly in Switzerland would not have problems even with metastasis.
So given that, as Pietro, you say, it's a relatively good prognosis after transplantation, Oscar's question is, would we risk a live donor here? If there's a good outcome, there should not be a reason to exclude a live donor approach if you cannot get this patient on a cadaveric waiting list. So is that your query, Oscar, whether
Absolutely.
you think it's suitable?
Yes, John.
Yeah.
That was my question.
Right. So what do the team feel? Would they feel that a live donor approach to this would be a reasonable outcome? If you look at the cost benefit to the donor and the outcome with a relatively good prognostic tumor, I would imagine that most would agree that live donor is okay. Would that be the feeling?
Mm-hmm.
Okay.
Yeah.
Okay, I think that's pretty clear. Would you have a problem, Oscar, locally listing the patient on a cadaveric waiting list?
Well, John, I stopped liver transplantation in 2015. I don't know how it managed now. So I have to address the patients to another liver transplant center because I do not perform anymore.
Okay, but you've got the go-ahead from the companion to do that. Prashant, have you got a question or comment?
Yeah, thank you. But I think that as far as the living donor question is concerned, I wouldn't change my indications from cadaver and living donor liver transplantation, especially in metastatic disease. So I would say no to this patient for a living donor. So in case of a metastatic disease, I would not risk a living donor unless I have so much of information and so much of evidence to say in a large group of patients that actually these patients would do well. So I would not change my indications for cadaver and living because I think that living donor is as important and as important a gift as a cadaver. That's the theory that we go by, and I would not change my indication.
So to be clear, you wouldn't list the patient.
Disease, Prashant, so far.
No metastatic disease. Okay, but on a matter of, on principle, Prashant, as you're saying, so if I follow you, you would not even do a cadaveric transplant for a patient with metastatic disease of this tumor. Is that correct?
Yes.
Wouldn't. Okay, fair enough. I mean, it's an exception. Pietro?
Unless there is sufficient literature to show that a consistent number of them go well, which I think is the case. I don't have the numbers here, but I think that the majority of patients with metastatic disease survive a long time.
But in this case, it's good for the patient. There's no evidence of metastatic disease, so I think there's a clear pathway here, Oscar. The opinion is for transplantation, and in your case, you refer to one of your colleagues to assess for transplant. Okay.
Okay. Thank you very much.
Good.
I appreciate your opinion. Thank you.
Thank you. Very good. Okay. Hugo, hand back to you.
Okay, so we have. I think Oscar had a. I don't know, Professor Bismuth, if we have time for a last case or not. I think Oscar had a.
Yes,
I have a short story. It's not even a case. It's quite unusual. Let me, please. This is a case of a 77-year-old man with history of coronary disease. He had an acute myocardium infarction and angioplasty with stents, and nowadays he was admitted for COVID-19 with pulmonary attempt, and he was put on low-weight heparin prophylaxis. He presented an acute digestive bleeding with severe hypovolemia, with arterial pressure of 80/50, cardiac rate is 120 per minute, and blood test hematocrit 22%, hemoglobin 8.5, and platelets 153. Given that situation, he went to urgent angiography, and it was shown some blood loss from the cystic artery. You can see some blush over there, here. So we thought that it was hemophilia, not real digestive bleeding, and this artery was embolized with cyanoacrylate. The cystic artery was embolized, the bleeding stopped, and patients recovered now in intensive care unit. So, what hypothesis of pathogenesis of bleeding do you think in this case, a rare case of bleeding coming from cystic artery? Let me say that the patient has the gallbladder. He had not cholecystectomy, so the gallbladder was still present. Have you seen this kind of bleeding sometime?
Look, it is very rare to have a bleeding in the gallbladder. But let me ask you some question. Of course, it is. The diagnosis is sure. The cystic artery was bleeding, but there was no jaundice.
No.
No pain in the abdomen.
Well, she was in shock. So patient he had pain, but not for the gallbladder issue. He had abdominal pain because of the bleeding and some also blood in the abdominal cavity.
No, okay. No gallstone.
No.
At that time, it could be a rupture of an aneurysm of the cystic artery. I don't see another, it's very rare anyway. It's very rare.
Valeria and angina.
Can I see again the CT scan?
Oscar, we had the same case this week. In a cirrhotic patient who had 1 month ago, a little bit less than 1 month ago, chemoembolization for HCC, which was not nearby the gallbladder, and he had hemophilia this week, a strong hemophilia, with the gallbladder full of blood. And so we operated on him. So my colleague operated him. Easy operation, so cholecystectomy. We didn't find the cause. There was no aneurysm of the artery, nothing else, and bleeding within the gallbladder. And there was no, the gallbladder bed was strictly normal. So there was no HCC bleeding or nothing else. But in gallbladder.
Oscar, I wanted to say something, two things. First observation, your patient is a naive, has no trauma at all, no gallstone, no liver disease. So this is not bleeding in the gallbladder, this is hemophilia. The only thing that you have to think about, and I agree with the fact that you have to look for microaneurysm, vascular malformation. My only thing is just to do a vascular mapping of the liver and the disease to see if you don't find micro angiopathy. That might explain why he bled in the biliary system, because this is not normal.
I agree. I totally agree. I totally agree with you, Gina. And let me see. I had a patient last year with multiple adenomas, and she was recovering from COVID-19. And I made a search in the literature, and it is reported that incidents bleeding in patients with in general admission with prophylactic anticoagulation is only 1%, but in patients with COVID-19 it duplicates to 1.8%. And there are some spontaneous major hemorrhage in COVID-19 patients, and it is thought that it's a perivascular inflammation with endothelial injury and disruption of intracellular junctions and basal membrane of endothelial cells. It means a microangiopathy caused by the virus. And I found a lot of patients with retroperitoneal hematomas due to ruptures of tiny vessels. And it could be a case, perhaps, of COVID-19 bleeding as a rare cause of microangiopathy caused by the virus.
Just one thing, Oscar. Sometimes these microaneurysms are associated with the stenosis of the celiac trunk. This was not noted.
No, it was not noticed. We saw some pancreatoduodenal aneurysm in arcuatum ligament, but not in cystic artery. But it could be also. But this was not. The celiac trunk was patent.
I agree, but only one remark. It is true that with the COVID, you have a lot of perivascular inflammation, but it's very rare, despite all the patient that has been admitted, that they have spontaneous rupture. This is hemophilia. So you have to accept that to bleed spontaneously, and I don't think that it was because he was under heparin that he bled. So I need to exclude that you don't have microangiopathy, because I've seen that. And you have patients who develop hemophilia. It's one of the causes that you have to exclude.
So I come back to hemophilia, the clinical symptomatology of hemophilia. It is totally typical to have what is called the triad of symptom, which is, of course, hemorrhage, GI hemorrhage. 2 is pain, and 3 is jaundice. That means when the blood, hemophilia means blood in the common bile duct, going to the duodenum through the papilla. This is why there is pain. But this is the typical symptom. So in your case, Oscar, it was this typical symptomatology also.
Two of the three, because the patient was not jaundiced. But
pain, no pain.
He had pain, and he had a hypovolemic shock.
And no jaundice.
No,
but
no
you
jaundice.
know, one thing we must be aware is that sometimes it could be an aneurysm of the hepatic artery opening directly in the duodenum. But this is not hemophilia, of course. Hemophilia means blood in the bile. This is, of course, the definition. And where this blood may come to the duodenum or to the GI tract, it's to the papilla normally. That means the blood may enter the biliary tract and go to the GI tract. We need this to define exactly hemophilia. The differential diagnostic is opening of artery, of the hepatic artery, for instance, of the cystic artery, perhaps, directly to the duodenum or another part of the GI tract.
That's what he saw. He saw blush on the cystic artery. This is what you showed us.
Yes.
So if it is in the cystic artery, so you have to imagine that maybe there was a rupture, but you need to exclude that you don't have another vascular abnormality. I mean, that's what I would do as a second step imaging, just to be sure.
Okay. Prashant?
Professor Bismuth, I just had a comment. Since you have so many students of hepatobiliary surgery, just like us, following you also on YouTube, and since you brought this issue of hemophilia, I wanted to ask you a question. 2 weeks back, we had a patient who had post living donor liver transplantation, had a bile leak, and there was, because of whatever reason, a stent was introduced. This patient had living donor liver transplant about 4 months back. They tried multiple ERCP stenting, and ultimately, unfortunately, the endoscopist ended up perforating the CBD. And there was a perforation in the CBD, there was a bile leak, and there was no other option. We opened up the patient and we did a Roux-en-Y hepaticojejunostomy. After suturing the bile duct, after dividing the bile duct low down, about 1 centimeter above the head of the pancreas, because the perforation was there. It was a very low down perforation. So we had to divide it and suture it. What happened was, very surprisingly, after about 5 days, the patient started having a GI bleed. And we did an endoscopy, and there was bleeding that was coming from the ampulla. So my thought initially was that probably there could have been a small pseudoaneurysm which developed at the site of the closure of that particular stump, which started bleeding. The other thing was that previously this patient had a sphincterotomy for doing the stenting. Now, the gastroenterologist wrote this, intervention gastroenterologist, and is of course a very experienced guy. He said that this is hemophilia. Now, would you actually define this as hemophilia from the actual definition of hemophilia? Because you just defined hemophilia now, blood entering into the CBD and then coming through the ampulla. So suppose there was a bleed that was happening. We did an angiography in this patient, and there was no bleed from any pseudoaneurysm at the closure of the stump. So ultimately, this could just have been bleeding which was happening from the periampullary lesion because of the sphincterotomy that was done some time back, and the patient became coagulopathic and started bleeding. So would you actually define this as hemophilia or no?
No. Look, if the bleeding is coming from the papilla, it is not hemophilia. From the bleeding is coming directly in the GI tract, but not through the bile duct. You need to have the blood in the bile duct, inside the bile duct.
So suppose it was an aneurysm which had ruptured into the bile duct.
In your case, the bile duct is very short, for it was cut. And so it was only the intrahepatic bile duct. So, of course, there is no bile. So, no bile. And but is the bleeding come from only from the papilla? It is not. For me, it is not hemophilia.
So I also did not agree with our gastroenterologist, and I fought with them about this definition that they say it is hemophilia. I did not agree with them. I told them this cannot be defined as hemophilia, and that's the reason why I just wanted you to make it clear this particular aspect. I did not agree with them as well. Thank you. Thank you for that clarification.
You have an excellent paper from Professor Bismuth in 1963, Hemophilia, in New England Journal of Medicine. Textbook.
I've read that. Yes.
This is correct. This is correct. I describe also hemoversolia, but I did not publish. Hemoversolia similar to hemophilia, but I did a lecture about that, several lectures, but I did not publish. But it was very interesting to if you find some case of bleeding coming from the versum. That means bleeding from the pancreas to the versum. It is hemoversolia, but not described, I think. But hemophilia is very. I have a discussion with Philippe Samblom. Philippe Samblom described hemophilia, and so we agree together. But I did this kind of small review in New England Journal of Medicine. It was my first paper in the New England. It's very long ago, very long time ago. But at that time, it was the beginning of the arteriography, GI arteriography. And indeed, my paper was to say, in every case of hemophilia, when you suspect hemophilia, you have to do an arteriography and to be ready to do surgery. I have patients dying from hemophilia at that time. This is why I start studying this.
Can I add one thing for the students? That generally hemophilia is self-limited unless there is a sphincterotomy. So you can take the patient down to CT scan and then to angiography. And today it is seen mostly because of percutaneous biliary drains that erode into an artery. And the reflex is to open the drain, but in fact, the reflex should be to close the drain to make it self-limited.
Always.
While you take the patient down to CT scan and arteriography.
Sphincterotomy induces something, there is no pain. For when you have the bile duct widely open, it is more severe. For the bleeding may flow very fluently in the GI tract. But aneurysm of the cystic artery, of the hepatic artery, may by rupture may open after in the bile duct.
Right.
So this is the way to have what is very difficult, mainly for after trauma, after abdominal trauma. You have a rupture of the hepatic artery of a branch, then open in the bile duct, and you have that time. It's interesting symptom. There are many causes. Look at my paper in New England. Thank you, Gina. You have a good memory. You have a very good memory.
It was written in my year. That's why I was born in '63. So that's why I remember. So I have it.
So we have now 3 minutes left. If you have a very short case, 3-minute case, nobody.
I may ask a practical case. It's a case that we are. That it's a current problem that we are having in the department now. Have you any experience on acute liver failure in patients that tested positive for COVID, for transplantation?
Say it again.
Young patient, 47-year-old, acute liver failure of unknown origin, and she has a routine test for COVID and it's positive.
Okay.
So she has an iron error of 5, a bilirubin of 28 milligrams per deciliter, AST is 3,500. She has encephalopathy, but she is not ventilated, and she is in fact in another hospital.
And you have the chest X-ray?
The chest X-ray, we don't have any information yet.
The chest CT scan, chest CT scan.
The CT scan, we ordered that, we don't have any info yet. Do you have some experience in acute liver failure and COVID?
No, but it is...
No, not yet, I hope.
No, it is two possibilities. Either the COVID is incidental and her disease it's separate. Okay, so you have to do all the workup for acute liver failure, liver biopsy, all the rest. Or either it's a consequence. But the consequence to have the liver failure secondary to a severe infection, that cannot come like that spontaneously. I mean, you have to imagine that this COVID, this patient probably is Delta, not Omicron. She should have been already in the intensive care unit, etc. It is a consequence. But it cannot be at the same time. I suspect it's an incidental finding, but now you have to do the whole workup of the cause of the liver failure, which can be either toxic or viral or drugs, all that. I will do everything, basically.
Yeah, there are reports of mortality in those cases of around 30 to 50%. After transplantation.
That's true. COVID is becoming a bad prognostic factor. You have if you see all the new series, it started in the States and everything, you really have a negative impact after transplantation with COVID.
The patient is in coma?
No. She has a grade 1 encephalopathy, but she's not ventilated. She's not in coma.
If she enters in coma, the risk of dying of the fulminant hepatitis is 85%. So you have to take the decision between 30 to 50% dying of the COVID or 80% dying without.
And ask for the type of the COVID that she's infected with, if it's Omicron or Delta.
You know that?
No.
Hugo, do you know that?
No, I don't know that.
The type of COVID.
No, this is just a problem that appeared during the meeting.
Okay.
So this is fresh news.
So it is a fulminant decision that you have to take.
Yes, in fact.
How old is she?
47.
47, okay. She's young.
But anyway, take the patient in your department. No?
Yes, I think so. It's at least to manage her next to us.
And then follow. If she don't enter in the coma, at that time you may wait until the moment she's in the coma, and then you have little time to apply this.
Prashant has raised his hand.
Prashant?
Yeah, you go. I think we discussed this also on another forum, but I think that as of now, with an INR of 5, with a bilirubin of 24, and given the expected outcome after transplant, I think that you should put her on other measures straight away, as in you should start looking at the ammonia, put her on CRRT, try to manage her if required with plasmapheresis, and try it over for about 3 to 5 days. I would say over 3 to 5 days, and it will manifest itself. Because usually the chest findings, it depends upon when she actually tested positive. There is a tendency for the RT-PCR to remain positive almost for a month in patients with low immunity, especially in patients with acute liver failure. But I would not take the decision straight away. I would give it at least 2 to 3 days to manifest in terms of chest. If the chest is involved, I would really not go ahead explaining whatever is the bad outcomes and the mortality after the transplant. If it were not to affect the chest, and if it's an incidental thing where you have an RT-PCR positive, but the other things are not very, I think chest is the key thing. And you would wait for about 2-3 days and try to support her with bridging therapy, whether it is CRRT, whether it is plasmapheresis, till that time. So at least wait for a period of 3 to 5 days, I would say.
This is an excellent proposal. Do you have artificial support?
Yes, we do.
What, Mars? What do we have?
Yes, Prometheus.
Prometheus? Okay.
Yes.
It's very good advice to gain 2-3 days and then to see. Thank you, Pasha.
Thank you very much.
Okay, so I think we may stop now. So only one thing, we decide between us to have a next staff end of February. Do you agree for that? Yes, the next staff. And then in March, no more staff will be in New York. I hope. Okay?
Yeah, it will come.
So Hugo, you start organizing the next staff meeting of the Compagnons end of February. And then we're ready to be in New York. I think that we have a program. The program is short in New York. It's only 1 day. It's only the clinical case discussion. And I think that, Hugo, we have enough case today that we sent to Jean. For Jean would like to print the program and to put the program in the official program of EHPBA. This is correct. So perhaps you have to send to all the Compagnons what you have already, the proposal of clinical case that proposed to you, to be sure, and to send the list to Jean.
I will share the Excel sheet with all the clinical cases for us to complete and to check.
Okay. Okay. Know the point. Thank you. Thank you, the family.
Thank you.
Au revoir.
Bon week-end.
Allez, bon week-end et bonne année encore à tout le monde. Voilà.
Bon week-end. All of you. And be well.
Bye. Bye. Thank you.
Bye-bye.
Merci, bye.
Goodbye.
Goodbye.
Henri? Ah non, il est parti. Voilà. Eduardo.
Nice to see you. Nice to see everybody.
Yeah. Ciao.
Como é que sai da reunião? Não sei como é que sai.